Good morning everyone and welcome to this clinical contact session for week 3. This week's topic was opportunistic infections and especially non-TB and non-CNS. So like every time we had 2 lectures from UW faculties. First lecture was on HIV-associated opportunistic infections by Dr. Robert, and second lecture was on opportunistic infection in HIV-infected adults in resource-limited settings, which was done by Dr. Susan. So I hope all of you might have gone through those 2 lectures. So this clinical contact session will be a kind of revision for all of us. And in addition to the slides presented by UW faculty, I have tried to incorporate the NACO guidelines in this clinical contact session, in this PowerPoint presentation. So please feel free to share your comments or ask your questions so that we can have a discussion on these topics which was discussed by you, the faculty. One more reminder is please complete your quizzes and homework assignments within the stipulated time so that you don't lose any marks, especially the weekly quiz. Homework assignments you still have time, but weekly quiz have a timeline. So please do that within the before the quiz date is over. So let's start with this week's session. Opportunistic infections, for those who are working in ART centers since years or since long time, they are well aware that which were the opportunistic infection we used to see before 3-4 years, in fact 4-5 years back, and slowly we are no more seeing those opportunistic infections that commonly, though we still see some of the opportunistic infections which are common, but the number has definitely come down with time. So as the name suggests, opportunistic, it itself stands for there are some infections or some diseases which are otherwise not so common in immunocompetent individuals, but because of immunodeficiency these infections have come back. So similar thing happened in 1981 when HIV was first diagnosed. In fact, these were the opportunistic infections which led to the discovery or diagnosis of HIV virus. There was a group of gay men who were admitted with some of the uncommon infections of that time like CMV or PCP, and also with the Kaposi sarcoma from New York and California. So when these people were getting admitted into the hospitals, people thought that this is some disease which is related to gay men. And initially this was thought that HIV is only disease of gay men, because the people who were getting admitted with these opportunistic infections were gay. So slowly everyone realized that that is not the case. This is the immunodeficiency which is caused by some virus named later as HIV, and that is now becoming a reason for infections, those uncommon infections, to attack the people who acquire those the HIV virus in their body. So this started from 1981 when OIs were seen in for the first time, or first documented for the first time. So the definition, if we try to study the definition of opportunistic infection, it is a disease caused by microbial agent in presence of compromised host immune system, and appearance of OI is needed for diagnosis of AIDS. So AIDS, as all of us know, is acquired immunodeficiency syndrome. So unless if someone has some infection but it is hidden and there is no sign or symptom, you don't call that stage as AIDS. Unless that is apparent, unless that is appeared, we don't call that stage of AIDS, because it is a group of symptoms, that is a syndrome. So an infection which is happening in a host which is whose immunity is compromised is called as opportunistic infection. Now, why do we need to know about OIs? Now, AIDS itself is defined as occurrence of life-threatening opportunistic infections or malignancies or some neurological diseases and other specific illnesses in presence of HIV infection with CD4 less than 200 cells per cubic millimeter. Now, a stage of AIDS, it is not always necessary that CD4 we should have the CD4 less than 200, but if someone has the opportunistic infection or those opportunistic infection which are categorized in stage 3 and stage 4, then that stage is called as stage of AIDS. Now, why we should know about it? Because unless we know about it, we cannot treat it. So proper management of PLHIV will not be done. So diagnosis is the first step. Then we treat opportunistic infection, and then we start with the other management of the PLHIV. Now, the development of these infections is dictated by multiple factors. One is exposure to the organism, that is infection in a person's body. Then the virulence property of the organism with which the PLHIV is getting infected, and also what is the immune level of the host. So host immune system. So if the organism is more virulent, and also if the immunity is very low, immunity of the host is very low, then again the risk of serious kind of opportunistic infections, for example disseminated presentation, is again high. Dr. Parvinder is facing some audio problems. I hope it is not there with everyone. If it is so, please check your internet speed again. So, okay, thank you, Praveen. So, what I was trying to say was, if organism is virulent, more virulent, and also if the host immune system is very weak, then there is risk of serious OIs, and serious presentation of OIs is more. So when does it occur? As we have already mentioned, it occurs when CD4 count declines, and depending on the CD4 we can predict the OIs also. So there are some specific OIs, at least the presentation of certain OIs is in a unique way at a certain level of CD4 count. First is level of CD4 count. We know that if CD4 count is very low, that is below 200, risk of serious OIs will increase. So if suppose a person comes with dyspnea and dry cough or fever for a few days, and on X-ray you are seeing nothing. So before thinking of some, and in PLHIV of course, so before thinking of some other reasons for this kind of presentation of dyspnea, dry cough and fever for few days, and with X-ray normal, if you know that CD4 is less than 200 in a PLHIV, then you will think of PCP before thinking of other diseases. Though the list of the differential diagnosis can be exhaustive in this scenario, but the PCP will be on the top of the list, especially if the person is not on Cotrimoxazole prophylaxis. So in this way, CD4 will help us in predicting the OI. CD4 count will help us in predicting the opportunistic infections. So most of you might have seen this figure, in which on the left side you will see the CD4 count, and on the right side you will see the timeline. If the CD4 count is higher, there will be specific OIs you can predict which will happen. As and when CD4 declines, the number of these OIs will increase, especially if you focus on the cutoff of 200. Below 200 you will see multiple OIs like PCP, esophageal candidiasis, and mucocutaneous herpes. Now you will see the same things here also. You are seeing oral candidiasis here, herpes zoster here, but this is of course herpes simplex. So the presentation will differ. Now oral candidiasis is again milder type of presentation, but if it is esophageal candidiasis, it has again gone down into the throat and esophagus. So it happens if the CD4 count is low. Similarly is with TB. Now TB can happen at any level of CD4 count, but if CD4 is higher, then the presentation of TB is more like of any other person who is HIV negative or immunocompetent persons. Like you will see upper lobe lesions, or you will see the well-formed cavities, or you will see the sputum positivity. So all these things will be seen if the CD4 count is good. But if CD4 count is declining, suppose TB happens if CD4 count is 50 or 100, at this point you will see a atypical type of presentation of tuberculosis. For example, you will see mid-zone or lower lung field tuberculosis, or mediastinal widening, more of extrapulmonary lesions like pleural effusion, or miliary TB, or disseminated kind of TB, or TB meningitis. So the presentation will be different, disseminated kind of one if the immunity is low. While if immunity is good, you will see a typical form of pulmonary tuberculosis with cavity formations. So similarly, if you see, there are some other OIs like Toxoplasma cryptococcosis and cryptosporidiosis, which you will see if the CD4 count is less than 100. It is not a rule, but the more commonly, if this happens, if when the CD4 falls below 100. So and some of the OIs like cryptosporidiosis, very rarely you will see if the CD4 count is good. So almost you will never see it. So and other diseases like PML, that is progressive multifocal leukoencephalopathy, which is a condition caused by JC virus, which is again a viral infection which is affecting brain tissues, and it will cause the leukoencephalopathy, that is whitening of the gray matter, and then CMV, that is cytomegalovirus infection, Mycobacterium avium intracellular complex. So all these things will happen, or we can suspect these things if the CD4 count is below 100. Now, and like I mentioned, the risk of seriousness of the presentation of these OIs will depend on the CD4 count. If the CD4 count is very low, there will be disseminated kind of infection, and if the CD4 count is good, then the OI which happens, for example, even tuberculosis, will be having a typical presentation. Now, herpes zoster, if it happens here, when CD4 count is less than 200, it may have like multidermatomal involvement of herpes, like stage 3 kind of illness. In India, there are multiple OIs which are commonly seen. Of course, tuberculosis is on the top. Other respiratory pathogens like streptococcus or influenza, you may see. Then you may see the intestinal organisms like Salmonella, Shigella, which may cause diarrheal diseases. Viral infections like varicella zoster, which causes herpes zoster, herpes simplex, that is HSV1 or 2. Then cytomegalovirus, that is CMV, which causes retinitis or encephalitis or other kind of presentation of CMV. Human papilloma, that is HPV, Epstein-Barr virus, which may cause the human papilloma may cause the CA cervix. Then Epstein-Barr virus may cause oral hairy leukoplakia or lymphomas. Then JC virus, which causes PML. Then fungal infections like Candida, Pneumocystis jirovecii or Pneumocystis carinii. Now this is some organism which has changed its position in categories. Earlier people used to think that this is a parasite, but then the present situation is people have agreed that this is something which is called as atypical fungus. So Pneumocystis jirovecii, earlier name was Pneumocystis carinii pneumonia, now it is Pneumocystis jirovecii. In NACO documents, you will see PCP only, that is Pneumocystis carinii pneumonia. Then Candida, everyone is aware that it may cause candidiasis, which most commonly oral candidiasis, but it can be again esophageal candidiasis and vaginal candidiasis also. Then cryptococcosis, it may cause cryptococcal pneumonitis or cryptococcal meningitis, and cutaneous cryptococcosis and other forms. Penicillium marnefi is a typical kind of infection which has some geographic preferences. So you will see this infection in northeastern region. We'll come back to a case study of Penicillium marnefi. This is not common in other regions of the country. It is caused by again fungus which is transmitted through bamboo rats. We'll come back to this. Then Histoplasma capsulatum, it is again a fungal fungus. So the presentation, if it is disseminated histoplasmosis, you will stage the patient as stage 4. Then parasites like Toxoplasma gondii, so it causes toxoplasmosis of brain cells. If you will see a typical presentation In session of CNS related OIs, we will go in details of toxoplasma. Then cryptosporidium, isospora, microspora, these are the intestinal organisms which cause diarrhea. So in PLHIV with immunity very low, you will see all these kinds of infection where cryptosporidium is most common one, but again in some regions isospora is more common than cryptospora. Unfortunately, there is nothing specific treatment, especially for the cryptosporidium. Once you start ART, there are many of the OIs like cryptosporidium, the JC virus infection or PML or even HIV associated nephropathy and other things which directly and organs which directly affect the some organs of the body. If you treat HIV infection with ART, the OIs again will disappear. So cryptosporidium is one of them. Then Giardia lamblia or Entamoeba histolytica and also Leishmaniasis. So Leishmania also is a situation where which is again not common in commonly called as Kala Azar. It is not common in all regions of the country, but especially those regions of North India where in regions of Bihar, UP, Jharkhand and West Bengal, you will still see cases of Leishmania. So these are some of the common OIs which are seen in India. Common OIs in male and female, I am not very sure of this kind of data. We may look for it, which are the OIs which are common in men and women. But in India, at least, there has not been any difference in especially acquisition of tuberculosis. But I never thought of actually that there should be a difference in men and women. But if there is any data on that, you can share with me, or also we can look at it later. As far as I know, there is no any preference if all other conditions are same. Like if there is same level of immunodeficiency, there will be again a risk of OI will be same to men and women both. But you can share if you have any data which says that there is a difference because of certain reason. But good question. Occurrence of OI depends on again multiple factors which we already discussed before. That is CD4 count. As we saw that if CD4 count is very low, the risk of OI is high. Then system involved, respiratory system, there are specific OIs have preferences for some specific systems. Like PCP, most common system which is involved with PCP is respiratory system. Cryptococcal meningitis, most common system which is involved is CNS. We mentioned about some geographical preferences like Penicillium marnifi infection in northeastern India, and also we talked about Leishmaniasis, which has preferences in in North India again, where in the region of Bihar, UP and Jharkhand. Then patient on ART or not. If patient is on ART, then obviously the viral load will go down, CD4 will increase, and also the risk of OI will come down. Now, till now, we used to think that it is only CD4 which decides the risk, but again lately it has been known that even if suppose if the viral load reduces, that also will reduce risk of opportunistic infection. We'll come back to this point where we'll see one study which shows that if viral load is undetectable, below detectable levels, then risk of OIs will be low. It was Kaposi sarcoma in male and vaginal candidiasis in female previously. I'm not sure about Kaposi sarcoma anymore because it is decreasing incidence due to ART. You are right in a sense that Kaposi sarcoma has never been common in countries like India. Again, the countries like many of the African countries, it had many cases of Kaposi sarcoma, but in India it was not common. So, and one of the reasons was also that association of Kaposi sarcoma with HIV type B virus was more than type C virus. And in India we have predominantly HIV subtype C. Vaginal candidiasis, I'll not call it as opportunistic infection as such in women, because otherwise also there are multiple factors because of which women may have vaginal candidiasis. I don't know how fair it will be to compare the diseases like Kaposis and vaginal candidiasis, but ultimately, actually, if you see in terms of clinical significance, I don't see any clinical significance in this scenario. So, in India, especially, if we see, the leading OI is tuberculosis, and in tuberculosis, we have not seen that difference. It is affecting men and women both similarly. So, yeah, so that is my response to that. So, common presenting symptom, most commonly people present with weight loss or anorexia or asthenia or weakness and fever, diarrhea. But people who have respiratory OIs will have cough, or in other words, it depends on the system which is involved. People who are having CNS OIs will have CNS manifestations. Like if you have, if someone has cryptococcal meningitis, then there will be some signs of meningism or similar signs and symptoms will be seen. But again, this is some presentation or analysis of the data which was again presented in the NACO OI treatment guidelines. The guidelines are being revised, so the revised version will be released soon. Now, the late presentation of presentation for ART. This has still been a scenario in most of the countries, not only in India, but also in many of the even developed countries or they have this problem of late presentation of people for ART. So there are multiple reasons for that. I'm not going into those reasons why people present late, but if you see the reality, even in NACO program, the earlier the presentation or the level of CD4 at which people used to present was close to like 120 or 130. Now that has increased to 250, around 250, 240, 250. So definitely there has been a change, but it is not the change which you or me will expect. Because if HIV is a disease or is an infection which is a lifelong infection, then there is no reason that patient should or the client should report late to the ART center. So it depends on again us to suspect more, diagnose people early and link them to ART centers. But late presentation is still a problem at multiple settings, and in fact in all settings, including high income countries and low income countries. But especially in resource poor settings, late presentation is associated with poverty, stigma, male sex and younger age, as it was reported in this journal, that is CID, in 2014. Where in resource limited settings there will be limited access to CD4 testing, and again the ART initiation is a problem. This will not be a problem anymore once the test and treat is rolled out in countries. Many countries already are now have rolled out test and treat, and India will also adopt that strategy very soon. But still, importance of CD4 testing, it remains. So it will guide us in again diagnosing the opportunistic infection. It will guide us to monitor the response to therapy. Of course, doing viral load will be a better thing, but still, at least for initiation of OI prophylaxis and stopping of OI prophylaxis, you will require CD4 testing. So what will happen if people present late? So there will be obviously increased mortality or morbidity, which is because of again HIV disease progression and development of multiple OIs, and HIV affecting organs of the body, important organs of the body like kidneys, liver, or intestines, or heart, etc., which causing HIV-associated nephropathy or HIV myocarditis and all that. So HIV transmission will again increase if the people do not report to the ART center early and are not put on ART early. So as and when there is a delay in ART initiation, there will be a risk of again transmission of HIV to the partners, and ultimately it may again get transferred to the or transmitted to the children. Then obviously life expectancy will be reduced. Then there will be increased health expenditure because of again multiple hospitalizations, and hospital cost will increase, and ultimately people will end up in spending more money in the hospitals. So mortality rates in some of the African ART treatment programs are higher in the first year. This was again as reported in Clinical Infectious Disease Journal. But even in our country, we have seen that most of the people they die within the first year, or in fact within 6 months of ART initiation. Now, between 8% to 26% of the patient beginning of the ART will die in the first year. Now you will say, what will be the reason if after starting ART, what is the cause of this early mortality? There is a strong correlation of more advanced disease, that is WHO clinical stage and CD4 count with early mortality. If you see this figure on the top on the left side, this is again survival curve which will say the probability of survival, and it drastically reduces if the CD4 count is low. You can see here CD4 count less than 50, and here it is more than 150, where the survival is good. So within an year the survival will drastically drop down if the CD4 at which a person is reported to the ART center is very low. And similarly, if you see WHO clinical stage, if clinical stage is stage 1 or 2 at the time when people report to the ART facility, survival is better. And if they present at the stage which is stage 3 or stage 4, you can see the dropping of the survival curve. So survival, it again depends, on probability of survival, it depends on at what clinical stage or at what CD4 count a person is reporting to the treatment facilities. If it is good CD4 and good clinical stage, then obviously survival will be better. If it is very low CD4 and very high or in later stage of HIV infection, then survival will be again poor. Now people have compared suboptimal CD4 recovery and also the risk of opportunistic infections. So this is one of the studies in East Africa in 7 of the ART sites, where more than 50% of them did not attain more than 500 CD4 even after 5 years. So incidence of opportunistic infection was higher in those patients who have suboptimal immune reconstitution. So if you see here that if nadir CD4, that is initial CD4, is less than 100, WHO's clinical stage is 3 and 4, baseline weight is more than 60, and male gender for some reason is associated with suboptimal immune reconstitution. So if the immune reconstitution is suboptimal, that is not as expected, then again there will be a more risk of opportunistic infections. So obviously it again brings us to the same point that if the immunity is not increasing, if you start ART early at higher CD4 count, and there will be a good immune response and there will be a reduced risk of OIs. Vis-a-vis if you start ART late and where there is a low CD4 count, there is a bad or not as expected or suboptimal immune response, and again risk of OIs will be more. Challenges of management in resource limited setting. First thing is diagnosis. Most of our ART center also, unfortunately, some of the ART center, they do not have basic facilities for the investigations. So if you want to have a definite diagnosis of some of the OIs, it is next to impossible in some of our settings. So technology is a problem which is not available in many of the facilities, and especially now when we are talking about test and start, and where more and more people will go on ART, you will require multiple facilities which can diagnose opportunistic infection if you suspect them, and then you can start treatment for those infections. But again, suspecting those infections and confirming with laboratory is important to treat those kinds of infections. But unfortunately, many of the institutions, they do not have basic facilities for diagnosing the opportunistic infection. So treatment is difficult. Again, cost of treatment and availability of certain drugs like, for example, ganciclovir or even amphotericin B, again supply chain and purchase of OI drugs, And unfortunately, there are some basic drugs like Cotrimoxazole. If it is not supplied by the program and if it is to be supplied by the health system, so do we have that quantity of OI drugs which is required for sufficient management of our patients or PLHIV? So these types of questions need to be answered in resource limited settings, and wherever there are facilities or wherever there is a possibility, these issues should be addressed at local level, because again this will be a lifelong thing, and wherever it is required, drugs need to be procured locally and should be provided to the PLHIV. And there can be again multiple interactions or overlapping toxicities with the antiretroviral drugs. For example, Cotrimoxazole, if you take an example, it can cause skin hypersensitivity reactions. Also, the drugs like efavirenz or nevirapine may also cause similar kind of reactions. So there can be overlapping toxicities. Similarly, anemia like zidodin causes anemia, and so do Cotrimoxazole. It may cause anemia. So it is fluconazole which I was talking about. So there are OI drugs which are to be carefully seen, which may cause anemia in addition to zidodin also. So algorithmic diagnosis and broad empiric treatment is the solution in such scenarios where you are not able to diagnose. So for example, if you take example of esophageal candidiasis, you don't actually take swab or esophageal the sample to confirm if it is esophageal candidiasis, and then you don't do that. If a person is complaining of like having some oral lesions and complaining of odonophagia, you treat them with fluconazole treatment. So that is all we can do in resource limited setting, that is empirical diagnosis and then empirical treatment after strong clinical suspicion. So WHO clinical staging, as we mentioned before, also stage 3, as and when the CD4 declines, the risk of again later stage illnesses like stage 4 illness or AIDS, the illnesses which are categorized in stage of AIDS will be more. This we have already seen in detail, like stage 1 is asymptomatic, stage 2, if we can just see broadly, weight loss less than 10%. This is just a revision for all of us. Herpes zoster, again seborrheic dermatitis, papular pruritic eruptions, some upper respiratory tract infections, angular cheilitis, onychomycosis. Then stage 3, weight loss more than 10%, fever more than 1 month, diarrhea more than 1 month, oral candidiasis, oral hairy leukoplakia, pulmonary tuberculosis, and some serious bacterial infections can be under stage 3. In stage 4, AIDS defining conditions, the list is exhaustive. So there are some certain conditions which can be again diagnosed by presumptive way, or clinical diagnosis is possible. For example, HIV wasting syndrome, pneumocystis, pneumonia. Like you will say that is it a presumptive diagnosis? Seeing it on X-ray is again a presumptive diagnosis. You are not, or it can be called as again clinical diagnosis, but we are not confirming that in lab. We are not isolating the pneumocystis carinii and we are not seeing that under microscope. So we are not confirming that diagnosis, but that will be called as a clinical diagnosis. So PCP clinical diagnosis is possible. Recurrent severe or radiological bacterial pneumonia, chronic herpes simplex. Now herpes, you need not do lab diagnosis for that. So herpes simplex, again we just seeing the clinical presentation, we start with the treatment, people respond to the treatment, and we document that as a herpes simplex. Esophageal candidiasis, same situation. Extrapulmonary tuberculosis, for example, especially in cases of abdominal TB, for example. You do USG abdomen, and under USG abdomen you will see the lymph nodes, and you will treat for abdominal tuberculosis. You will start category 1 for that patient. But it is, we have not again isolated the organisms, we have not taken any biopsy, we don't see any histological picture of that lymph node. We just assume that this enlarged lymph node can be because of tuberculosis, and we started with anti-TB treatment. So most of the situations, extrapulmonary TB also is diagnosed as a clinical diagnosis, Then Kaposi sarcoma, again there are lab facilities are not again very well equipped to document Kaposi sarcoma. Again, lab diagnosis itself is a difficult thing to be done. Then CNS toxoplasmosis, again we see the MRI or CT scan, and based on the presentation we document it as toxoplasma. Of course, we correlate that with CD4 count and other factors, but we don't take brain biopsy to isolate the organism, so that we don't do. HIV encephalopathy, obviously we don't have anything to diagnose this kind of condition, so this is just a presumptive or clinical diagnosis. Similarly, in the list of stage 4 condition, there should be there are conditions where you must need the confirmatory diagnostic test, or you need the lab confirmation, like extrapulmonary cryptococcus, including meningitis, disseminated non-tuberculous mycobacteria. Then PML, there are some investigations which are done for PML. Of course, MRI findings are good enough to start patients on treatment and to document PML. Then Candida for trachea, cryptosporidiosis or isospora. Again, just labeling as a patient of diarrhea, you cannot say that patient is having cryptosporidial diarrhea. So, but this is important. Unless you document that, or unless you your lab confirms that this is cryptospora, you cannot stage that patient as stage 4 condition, right? So, if a person is having suppose diarrhea for 2 or 3 days, and you don't know the cause of the diarrhea, you are treating just like that, and then you started with the ART, patient responded. Now, unless you have the lab diagnosis, you cannot write the diagnosis as a cryptosporidial diarrhea. And if you don't know the cause, you cannot stage the person as stage 4. And that is why this comes in under this list. Then visceral herpes simplex infection, cytomegalovirus infection, then any disseminated mycosis, recurrent non-typhoidal salmonella, lymphoma, invasive cervical cancer, visceral leishmaniasis. All these things will require a lab diagnosis to confirm. Though it is called included in the list of clinical staging of OIs, but you require a lab confirmation for reporting these conditions. Few things about Indian geography, where there are some OIs in specific geographic regions. Malaria, HIV infected. Now there is a strong correlation between malaria and HIV in terms of the fact that PL-HIV are at increased risk of clinical malaria, and co-infection with malaria and HIV, it increases the viral load of HIV. That means if a PL-HIV gets malaria, it increases the viral load of HIV. Then the malaria in a PL-HIV will be more severe, and also the response to the therapy is not as expected. How we treat malaria is as per the national guidelines. There is no difference in treatment of malaria in HIV positive and HIV negative. Visceral leishmaniasis, we already discussed that it is common in, it is again endemic in some of the regions like Bihar, Eastern UP, Jharkhand and West Bengal. Patient present with fever, hepatosplenomegaly, chronic relapsing course is seen in 2/3 of patients, and organisms can be isolated from bone marrow aspirates. Treatment of visceral leishmaniasis is with the standard therapy with injection amphotericin B. Penicillium, as we talked about it, it is a disseminated infection and fungal with a fungus called Penicillium marnefi, and it is recognized as a complication of HIV infection, especially in the region of the northeastern India, like Manipur and other states of northeast. It is transmitted by bamboo rats in common and is common during the rainy seasons. Clinical features are fever, generalized lymphadenopathy, hepatosplenomegaly, anemia, papillary skin lesions, etc. It is caused by a fungus which is a dimorphic fungus, that is Penicillium marnefi. It is one of the AIDS defining illnesses. That means if it is seen, then person will be staged at stage 4, and clinical features will have fever, papillary rash with central umbilication over face, ears, extremities which looks like molluscum, may also be associated with lymph node and hepatic involvement. You can see the picture here. how the papules and everything you can see here, it looks like molluscum and is typically seen in northeastern regions where it is endemic. Then amphotericin B is a treatment of choice for 2 weeks, and which is followed by oral itraconazole for about 10 weeks. Secondary prophylaxis is advised with itraconazole for period for at least 6 months, or actually it is until the period if the CD4 is more than 200 after ART initiation and sustained at least for 6 months. But again, unfortunately, relapses are common. Now, what about the people who are on ART? Are the OIs common in that category? OIs can happen in those patients also, especially once the patients are newly initiated on ART because of the subclinical infection, which is not apparent before initiation of ART. Once you start ART, people or ART will increase or will strengthen, restore the immune response, and the restored immune system will find that organism which is hiding the body, and in that process you will see a clinical presentation of OIs. And if it occurs within within a few weeks after initiation of ART and with marked rise in CD4 count, it is called as immune reconstitution inflammatory syndrome, that is IRIS, which we spoke about in the last session. So I'm not discussing IRIS in this session, though the University of Washington faculty has done that, because of the only fact that we already discussed IRIS in the last clinical contact session. So OIs may occur as a manifestation of failing ART regimen. So if you see stage 3 or some of the stage 3 or mainly stage 4 OIs, so that is a definition of ART treatment failure or clinical failure, it is called. Infections that are seen in patients on ART, infection and treatment is similar to the ART naive patients, these are not very not different in any way. And in event of IRIS, there is need to use anti-inflammatory drugs, as we saw in the last session, especially if it is a paradoxical kind of reaction. The steroid usage will be very helpful. About pregnancy, OIs may develop during pregnancy because pregnancy itself is a condition where there is a weakened immune system. So the pregnant women are prone for infections, and or top of that, if PLHIV becomes pregnant, there will be again increased risk of OI, especially in the postpartum period. Diagnosis and treatment is very similar in pregnant and non-pregnant patients, but again, diagnosis for pregnant women who have had an OI diagnosed and are not on ART, immediate ART initiation with OI therapy should be encouraged to minimize risk of perineal transmission or perinatal transmission of HIV. Because if a person is pregnant having again high viral load with some opportunistic infection, risk of transmission of HIV to the baby will increase multiple folds. And some of the drugs which we use for treatment of OIs, they may have some teratogenic effects. So especially in the first trimester, physicians or clinicians should be careful in using these drugs. And there should be an ultrasound which should be regularly done, especially at 18 to 20 weeks of gestation, where the organ development is almost complete. From there, the detailed ultrasound examination need to be done to again detect major possible abnormalities. Then what about the prevention of opportunistic infections? Can all OIs prevented? Maybe not. All OIs may not be prevented, but there are some common OIs which can definitely be prevented very easily. Drugs is one thing which can prevent development of opportunistic infection, but that is not the only thing for prevention. There are other common things which are to be tried for OI prevention, that is starting patients on ART. Like we mentioned before, that once you start ART, viral load reduces a lot and CD4 increases. Even reduced viral load also will protect people against opportunistic infection, and so do the increased CD4 count. Then simple lifestyle measures like proper nutrition, protected water supply, wash vegetable before cooking. These are simple measures which will avoid the entry of organisms in a person's body. Then personal hygiene, like hand washing before eating, gargling after meals, eating properly cooked meals, or brushing teeth regularly, especially during night time. All these things are important for PLHIV to avoid infections. Then there is a role of definitely prophylaxis, that is Cotrimoxazole prophylaxis especially, which prevents development of multiple OIs. We'll come back to Cotrimoxazole prophylaxis in detail, we'll see that. Then vaccination against the diseases wherever it is available. For example, hepatitis B, we have definitely the vaccine which is available, pneumococcal pneumonia. Especially when the CD4 count is 250, these kinds of vaccination should be encouraged. Then what has to be considered? The prophylaxis to prevent opportunistic infection. Consideration, there are some special considerations which are to be made, like infection should be common and or predictable. Now you have seen that there are some geographic preferences, not only within the country but also within the regions. There are geographic preferences. So in some of the regions, some of the diseases are common where the prophylaxis for that particular OI should be given. So it is not general one rule that all PLHIV will receive all these kinds of prophylaxis. That is not the case. So infection should be common in that region and should be predictable, like what we saw. If the CD4 is less than 200 in India and also most part of the world, you will give prophylaxis with Cotrimoxazole. And then infection should be clinically significant. There are many infections which are not clinically significant, for which obviously you will not require any prophylaxis. Prophylaxis should be effective, non-toxic and affordable. All these factors are important to be considered before you start any prophylaxis in any patient. So there are two types of prophylaxis. First of all, why do we need to give OI prophylaxis to HIV infected persons? This study was again presented in the those two lectures by UW faculty, where there is a precision of OI prophylaxis criteria. Not only CD4 count matters. See, if you look at the numbers here, this is viral load, okay, and this is CD4 count. This is CD4 count less than 100, CD4 count between 101 to 200 and more than 200. So this is an observational cohort of 23,000 patients. So 253 cases of PCP were seen in a period of follow-up. There is a low rate of PCP in those with CD4 count between 100 to 200 and viral load of less than 400. Now, obviously, if CD4 count is more than 200, you will not have again many cases of PCP in that scenario. If it is less than 200, you will have cases of PCP. But CD4 count between 100 to 200 and viral load, if it is very high, there will be a risk of PCP. But if viral load is low, then the risk of again PCP will drop down. So this is the difference. We always think that if the CD4 is low, risk of OI will be high. If CD4 is high, risk of OI will be low. But it is not only CD4 that matters, viral load also matters. If viral load is reducing, the risk of again, for example, if you read here, low rate of PCP in those with CD4 between 100 to 200 and HIV RNA less than 400. But similarly here CD4 is between 100 to 200, but if viral load is high, you will see the risk of PCP. So OI accelerates HIV disease progression, and that is our rationale for prophylaxis. What happens is, if you have OI, then there will be activation of CD4 T lymphocytes, and the accelerated host DNA translation to pro-viral DNA will happen, which will obviously produce more and more HIV virus that will increase the viral load. Increased viral load will cause more destruction of CD4 cell, and CD4 depletion will cause again OI. So this is a vicious cycle which will go on unless you break the cycle with ART or prophylaxis. Then what is the difference between primary and secondary prophylaxis, which we were talking about? Primary prophylaxis is something which is given prior to the infection happens, and it is given to prevent the first episode in high risk situation. While secondary prophylaxis is something which is given after the infection has happened and you have sufficiently treated the infection, then to prevent the recurrence of infection from occurring in high risk situation, you give secondary prophylaxis. So that is the main basic difference between primary and secondary prophylaxis. Now we have seen the graph where we can now, I think, in a position to categorize the OIs based on the level of CD4 count. If the CD4 is less than 500, which are the more common OIs as compared to the common OIs if the CD4 is less than 100 or 50. So here we can again see that list again. If CD4 drops below 50, there is a risk of disseminated CMV in those situations, and also if it is dropping below 100, you may see candidial esophagitis, cryptococcosis, disseminated HSV, that is herpes simplex virus. Below 200, you will have all these in addition to extrapulmonary tuberculosis, cervical extrapulmonary tuberculosis. But there are some other conditions which are again common or which can happen at any level of CD4, which includes pulmonary tuberculosis, pneumonia, bacterial infections, herpes zoster, then cervical cancer and other things. So again, we can predict the OI based on CD4 levels. This is data from Indian records, the records which we provide to NACO. Obviously, this is from our MPR basically. The MPR of the ART center, where in section of OI reporting, where most of the centers they just write numbers. I don't know from where they count those numbers, but there is a definite mechanism. If someone wants to know that mechanism, please refer to operational guidelines of NACO, where there is a chart in which you need to record number of OIs or which OI you are seeing at your OPD. So that you should sit with that sheet on your table, which is there in the operational guideline, OI summary sheet, daily OI summary sheet. Every medical officer is supposed to have that sheet under his table every day, and it is staff nurse who should collect that sheet at the end of the day from the medical officers, and at the end of the month there should be a monthly summary of that OI sheet, and data manager will report that. And this data is from those monthly reports where people had reported opportunistic infection. Obviously, we are reporting tuberculosis more, but there are multiple OIs which sometimes we see, but we are not able to report. So just as a side comment, please note that reporting of OIs from ART center also is very, very important. Otherwise, what will happen is slowly funds will get dried, and we will not. And most of the centers, this is happening that we are not receiving OI funds in many of the centers now. If you have OIs and if you are not reporting those OIs, then that is again grave mistake, because if you don't report OIs, you will never get funding for OI treatment. Now, what is the effect of HAART on opportunistic infection? Again, we already saw that there will be a declining incidence of opportunistic infection, reduced need for prophylaxis, spontaneous improvements and cures. There are some diseases which I mentioned before also that do not have any specific treatment. If you start ART in those patients, those diseases will automatically get cured. Then immune reconstitution effects will happen with HAART, or highly active antiretroviral therapy. HAART stands for highly active antiretroviral therapy. So these are OIs which are treatable with ART alone. Like I mentioned, PML, which is caused by JC virus, there is no specific treatment for these diseases. You just start with ART, and slowly these OIs either will be under control or will get cured. Some of the OIs in advanced stage will not get cured, and they will not again. Patients will not be like a pre-OI stage ever. Like then cryptosporidiasis, microspora, Kaposi sarcoma, mycobacterium, avian intracellular complex sometimes will fall under this category, though you have some specific treatment for that, like clarithromycin and ethambutol, rifabutin, and other things are available for MAC. Then diseases that potentially require prophylaxis, PCP is definitely one of them. Then Mycobacterium TB, we give INH prophylaxis. We'll talk about it in the next OI session. Then MAC, there is again a controversy here in the national program. In adults, you don't recommend MAC prophylaxis. Of course, see the point which I mentioned already, that it depends on prevalence of disease in that region. If the prevalence is more, there will be a national guideline for prophylaxis with some for chemoprophylaxis. But if it is not there universally everywhere, it cannot be similarly applied. For example, in the Western world, you will have the guidelines for prophylaxis of MAC infection even in adults. But in Indian guidelines, you will see these prophylaxis guidelines for MAC are only in pediatric and not in adults. I'll come to that point again. Then cryptomeningitis, candida, toxoplasma, CMV, retinitis can also fall under this list. Now, cotrimoxazole is very helpful in preventing multiple diseases like pneumocystis jirovecii or carinal pneumonia, toxoplasma, even some other diseases like malaria. So it can be prophylactic against multiple diseases. And in situations where we are not able to use cotrimoxazole, we use dapsone. So it works against these diseases like PCP, toxoplasma, bacterial pneumonias, non-typhoidal salmonella, nocardia, isospora, cyclospora, and plasmodium falciparum, which causes malaria. Cotrimoxazole is anyhow beneficial. Our guidelines at present are 250, the cutoff of 250. If in CD4 is less than 250, you start with cotrimoxazole prophylaxis, though the cutoff will very soon change to 350. But I think in the records which we have at present from NACO, the cutoff is 250 to initiate prophylaxis. But NACO has agreed to in the next guideline, which is coming up very soon, the cutoff will be, you will see that it will be 350 and not 250. So in this study from rural Uganda, 509 PLHIV, enrolled 509 PLHIV and again 1500 HIV negative individuals, and who were observed for 5 months and followed for 1.5 years. And you can see this mortality reduced by 46%. Nausea says it is presently 350. If you have received that communication from NACO, that is absolutely correct. So now it is 350, and if you have not received that communication, you will receive it very soon. In the next guideline, it is being revised. In the guidelines which I've seen earlier, it is still 250. Even in presentations I checked, it is 250. But NACO has agreed in principle everywhere, and it is coming up in the next guideline that cutoff will be raised to 350 for initiation of cotrimoxazole. So mortality reduced in this study by 46%. Malaria again incidence reduced by 72%. Diarrhea reduced. Hospitalization again reduced. And clinic visits reduced. So it was very beneficial if you give cotrimoxazole, even if the CD4 count is good. And moreover, it also was found beneficial for the family members who were HIV negative. Especially incidence of malaria, it was reduced by 38%, diarrhea reduced by 41%, hospitalization again reduced. Because of the again cross infections and other things, this definitely had an effect. Can others see video? Only audio is coming to Dr. Saeed. Are the slides visible to everyone? Okay, thanks Praveen. You can guide Mr. Shibli. So on the top of the list, you will see PCP and toxoplasma. Or for other diseases in national guideline, the prophylaxis is not, primary prophylaxis is not indicated. Maybe secondary prophylaxis is. We'll come to that later. but primary prophylaxis is indicated only with Cotrimoxazole, and these days we use also for TB like INH prophylaxis. That will be discussed later in TB session, but for this session it will be a PCP and toxoplasma for which we are using this prophylaxis, especially and there is only one drug which we are using, that is Cotrimoxazole. Now this slide I have taken from some old presentation which is not there in the very recent presentation, and also I checked the recent presentations of NACO. It has been mentioned less than 250, but as I mentioned that very soon it will be 350 if you have not already received that communication from NACO. And when it is to be discontinued is when CD4, at least 2 subsequent CD4s, if there are above 250 for 6 months, you can stop that. This slide is from the recent NACO presentation. When to commencing primary CPT in all WHO clinical stage 1 and 2 if CD4 count is less than 250, stage 3 and 4 if it is more than stage 3 and 4 regardless of CD4. If you have already received that communication of 350, please read this as 350. As I did not find any slide, I have not put, but as Dr. Anamika mentions, it is more than 350. That is absolutely fine. It is correct. I have copied the slide from the recent presentation, but I think in that presentation, this guideline was not updated. So if it has been communicated from NACO as a 350 cutoff for initiation and stopping of OI treatment, please follow that. Commencing secondary prophylaxis and also WHO guidelines we will see in the next couple of slides. It mentions the cutoff as 350 and not 250. So for all patients who have completed successful treatment for PCP until CD4 count is more than 250 maintained over a period of 6 months, that means again you can read it as 350. If CD4 count is more than 350 at least for 6 months, you can stop OI treatment. Timing of initiation: start Cotrimoxazole prophylaxis first. Start ART 5 to 6 days after start of CPT. And don't start it on the same day, because sometimes what happens is there will be overlapping toxicities and you will not understand which is causing that intolerance to the patients. And also, while you are preparing the patient for treatment, patients will have some tablets to have. Otherwise, if you keep patients waiting for a long time, then again patients also will it will not be satisfying for the patients. Then meanwhile, make use of this time for treatment adherence and preparation. Then dosage of Cotrimoxazole, there will be one double strength or 2 single strength tablets per day which will be required. Cotrimoxazole, everyone is aware that it contains 2 drugs, sulfamethoxazole and trimethoprim. Sulfamethoxazole will be given a dose of 800 mg in double strength tablets, and trimethoprim 160 mg. Single strength, the dose will be high, half. As per WHO 2013, recommended for all adults including pregnant women with stage 3 or 4 and or CD4 count less than or equal to 350 in settings where malaria or severe bacterial infections are highly prevalent, recommended regardless of stage or CD4, and recommended for all PL-HIV with active TB disease regardless of CD4 count, which we are already following. When to stop? Now, if suppose you are starting Cotrimoxazole in everyone, then when to stop? Trials in adults and children have shown benefits at any stage of count. In a study of 758 HIV positive children, those who stopped Cotrimoxazole, higher rate of hospitalization or death. Malaria and bacterial infections drove again this difference. If you can see the survival curve here, this is continued treatment and this is stop treatment. If you stop treatment, again survival is coming down. If you continue prophylaxis, survival is again better as comparison to the other scenario. Then stop all for adults including pregnant women when clinically stable on ART with evidence of immune recovery and viral suppression. Now, evidence of immune recovery, we are taking it as CD4 count above 250 or 350 or whatever is the cutoff, and viral suppression we obviously are not seeing, but as we already saw that if viral separation is good, then we can risk of OI will reduce. But if there is again viral load which is higher, then there will be again risk of OI or PCP especially. Continue indefinitely for children and adults in settings where malaria or severe bacterial infections are highly prevalent. For children 5 or older in settings with lower prevalence of malaria and bacterial infection, discontinue if clinically stable or virologically suppressed for more than 6 months with CD4 count more than 350. Now this is again general international recommendation including WHO recommendations. Again, like I said, this slide I have taken from NACO slide set, but this you can read as more than 350. When to stop? If CD4 count is more than or equal to 350 for at least 6 months, or more than or equal to 250 for at least 6 months, and if patient is on ART for at least 6 months, is asymptomatic and well. If CPT is started at CD4 level between 250 to 350, CD4 count should have increased. Patient is on ART for at least 6 months, is asymptomatic and well before CPT is stopped. Now for children, as per WHO, it is recommended for HIV exposed infant 4 to 6 weeks of age. What is HIV exposed child? It means a child who is born to HIV positive mother. Continue until breastfeeding is stopped and HIV infection is excluded. So after 4 to 6 weeks, we need to start Cotrimoxazole for all HIV exposed babies. That means babies who are born to HIV positive mother, and continue until at least the breastfeeding is stopped and the HIV infection is ruled out. Recommended for infant, children and adolescent with HIV irrespective of clinical and immune condition. Priority to children under 5 years of age and those with stage 3 or 4 with CD4 count less than 350 is the priority. So initiation, if ART is indicated, start Cotrimoxazole first, prophylaxis, clinically monitor, nausea, vomiting, rash, ectasis, etc. Then preparatory and adherence counseling 2 weeks later if tolerating, add ART. Now again, it may not be 2 weeks, it can be started within 4 to 5 days. Cotrimoxazole prophylaxis, this is the dose which we already saw this slide, and this is in pediatrics, 5 mg per kg per day. But there are some problems with Cotrimoxazole. As I mentioned, one problem of the skin reactions. It may cause itchy rash in some minor reactions. Treat with antihistamines. Now, every reaction is not Stevens-Johnson or will not lead to Stevens-Johnson's. There can be some minor reactions where you can give antihistaminics and like CPM or cetirizine, that will be fine. But there can be moderate to severe reactions also. With antihistamines and steroid, cessation of therapy is required. Stevens-Johnson syndrome is again very serious life-threatening condition where you can no more challenge that drug, which may cause again desquamation of this kind. Rarely it can cause kidney problems, but the good thing is about Cotrimoxazole is we can desensitize and restart safely after all but major reactions. If there are major reactions like Stevens-Johnson and all, please don't try it. Dapsone is an alternative, but still Dapsone is from the same group, and it may only the other problem with Dapsone is it may only protect PCP but not the other diseases like bacterial pneumonias or toxoplasma. It is not recommended for use for if the CD4 is more than 200. So the toxicities can be graded from grade 1 to grade 4. Grade 1 is erythema, grade 4 is exfoliative dermatitis or Stevens-Johnson's. And in this slide, it has been given that what is to be done if there is a toxicity or if there are skin toxicity because of Cotrimoxazole. In grade 1 or grade 2, that is erythema or diffuse maculopapular rash or dry squamation, you can still continue Cotrimoxazole with careful and close observation, and also with some drugs like antihistaminics if they are available. But In case if there is a vesiculation or mucosal ulceration, that is mucosal involvement is there, that is grade 3, the use of cotrimoxazole should be discontinued until there is complete resolution within a couple of weeks, and introduction can be tried with desensitization, can be considered. But if there is any stage 4 or grade 4 toxicity like exfoliative dermatitis, Steven-Johnson syndrome, that is SJS, erythema multiforme or moist desquamation, then cotrimoxazole should be permanently discontinued. This is actually general rule for any toxicity, in fact, if you see. So if patients are allergic, you can use dapsone as OD or children 2 mg per kg per day. If not possible, consider desquamation. And desensitization 2 weeks after reaction only if grade of hypersensitivity is less than 3. And these are the dosages we use in desquamation on day 1, 2, 3, 4, 5 and 6. And slowly you start with very low dose and you continue giving the increasing the dose. Over a period of 6 days you can desensitize these people. In pregnancy it is same. It is same to use in all trimester. Breastfeeding also is not a contraindication. MAC in NACO program there is no adult prophylaxis which is recommended. But for pediatric it depends on again CD4 and age. The prophylaxis can be given with clarithromycin, that is 7.5 mg per dose BD, or azithromycin, or and also, like I mentioned, it needs to be given based on the level of CD4 count and age of the child. So similarly, doses are calculated. It need to be stopped when CD4 count level is above threshold for 3 months. Primary prophylaxis is required for CLHIV with CD4 with WHO clinical stage 4. Iris we already saw in the last class, so we will not be touching upon it. The other OIs are like oral candidiasis. You can clearly see this. There is an involvement of soft palate also, so it may be an esophageal candidiasis as well. So if you have odynophagia, that is painful deglutition or pain while deglutition, most common causes in HIV, in PLHIV are fungal, for example, candida. But if suppose you